Good afternoon, everybody, and welcome to the April 22nd Medicine Grand Rounds. I'm pleased everyone can join us today because this is a special day. We have an invited guest speaker, Dr. André Mansoor, who's an associate professor from Oregon Health Sciences, OSU in Portland, Oregon. And he is invited as our Shaia family lecturer. And I thought I'd just share a little bit about the Shaia family with you before I more formally introduce Dr. Mansoor. So Harry Shaia opened actually a store restaurant on the MVCVP campus way back in 1924. And that restaurant changed its location and its name, but eventually became known as the Skull and Bones Restaurant. And after 72 years in business, remarkable length of time for business for a restaurant, closed in 1997. And really it was a favored haunt of MCVP employees and patients and their guests, and became a kind of informal lunch club of sorts where faculty and students could meet together and discuss clinical problems and exchange research ideas. Ed Shaia and his brother Richard established a fund in 1965 in honor of their parents, Harry and Zakiya Shaia. And they then designated a fund for an annual lecture on the topic of medical education here at the Department of Medicine School of Medicine. So this has really been a tradition. We've had great people come and give this lecture in honor of the Shaia family, who've really been some important members of our community. And I think at least 9 members of the family have attended university here in the MCVP educational offerings. So this year, we're really pleased to formally introduce Dr. Mansoor, who is associate professor, and I had a lovely time chatting with Dr. Mansoor and just learning about his approach to clinical bedside education and some of the things that they're doing there. So it was really a fun time to get to know you. So Dr. Mansoor did his BS at the University of Portland and then stayed in Oregon, where he did his MD, rose up through the ranks and was chief resident there, and has now really joined their hospital medicine division, where he really makes a great effort in the educational frameworks and really a systems approach for teaching medical education, and is involved at all levels of education from medical students to residents particularly. He's written a textbook which is about the framework of internal medicine, and I think will fit really nicely with his art and science of diagnostic reasoning today. You know, he's clearly a wonderful educator, and I was reading his list of accomplishments, and a couple I'd just like to call out. He won the Gold Humanism Award, as well as almost every year has won the Faculty Award from the residents for teaching. So I'm glad I'm not your colleague, because I think you might be hard to compete with for these awards. But that obviously speaks wonders to your abilities and the way in which you're held in esteem at your institution. So we're really delighted to welcome you here and really look forward to your thoughts on the arts and science of diagnosis.
Thank you so much for that wonderful introduction, Dr. Simon. Thank you for providing the background of the Shaia family. I'm honored to be here and to speak at this conference. Let me share my screen here, and I'm going to optimize for video and audio, and I would ask that all of you guys do the same. There are a few videos in this talk which have audio as well. And so if you can optimize your viewing experience, that would be great. So let me just share my PowerPoint, and hopefully you guys can see this. Is that coming through okay?
Perfect, thank you.
Great. So this is a talk on diagnostic reasoning, and it's based on a textbook that I wrote called Frameworks for Internal Medicine. And normally this is an interactive talk, and I won't do that given that this is a grand rounds, but feel free to use the chat to interact with me during the talk. In fact, let me pull up the chat now so I have that in front of me. Feel free to do so, or unmute yourself if you'd like. So let's get started here. And in terms of the objectives, we're first going to kind of review the steps that a clinician takes to arrive at a diagnosis. And then we're going to discuss the framework system and sort of apply it to a case. And in doing so, we're going to develop an approach to hypoxemia. So we should begin by asking the question, what is diagnostic reasoning? And I think that you'll get different responses depending on who you ask. But to me, diagnostic reasoning is the skillful acquisition and use of clues from a patient's history, exam, and other data to make a diagnosis. It's similar to how a detective will gather and use clues from a crime scene to solve a case. And it's the acquisition and use of clues with an emphasis on acquisition. You could have the same crime scene with the same information in it, and you could have 10 different detectives evaluate that crime scene, and some of them are going to glean important pieces of information from that crime scene that others gloss over or miss entirely. And the same is true in medicine. As clinicians, it's our responsibility to recognize and acquire those clues from patients that we later use to make a diagnosis. And the process of making a diagnosis is a skill and an art form that requires understanding and lots of practice. And I think that that's where we should be focused on in terms of medical education of our students and residents. I think we spend an awful lot of time focused on treatment and management. I see students and residents memorizing treatment and management algorithms for their standardized tests, and not enough time developing diagnostic acumen. That's where most of the cognitive load goes, and it is into making a diagnosis. For example, making the diagnosis of acute pericarditis. That's the hard part. And now from there, you can simply look up the treatment, whether it's an NSAID or colchicine, and what the duration of therapy should be. But the process of making a diagnosis is not so straightforward. It can't simply be looked up in the way that treatment and management can. To make a diagnosis, a clinician has to, at the very least, do three things. Number one, clinician has to know what information is important to acquire from a case. We don't want to be the type of clinician who asks a head-to-toe review of systems on every patient, hoping to stumble upon a clue, or perform a head-to-toe physical examination on every patient we see, hoping to stumble upon an important physical finding, or order every lab test imaginable on every patient we see, hoping to uncover some abnormality. We want to let the information from the case as it comes to us allow us to develop hypotheses, and those hypotheses will guide us and tell us what information we need to extract from the patient, whether it's a history or exam or laboratory or imaging data. But it's not enough to know what information is important to acquire. We have to have the skills to acquire that information. For example, we may recognize that the lung exam is important in a particular case, but that's totally useless if we don't have the skills to properly examine the lungs, if we can't percuss that dullness, or we can't auscultate those rales. And so it's important to know what information is important to acquire and have the skills to acquire that information. And then we take that information and we synthesize it to make a diagnosis. And all three of these steps are related. Without one, you can't do two. Without two, you can't do three. And without three, you can't make a diagnosis. And I mentioned standardized tests, which certainly play a role in medical education, but perhaps too large of a role, in my opinion. I think they're an imperfect measure of how well someone is going to be at being a clinician. To me, they create a fantasy world where you're given all of the clues and information that you would need from a case in order to solve it right up front on a silver platter. They tell you the patient was in India last month. They tell you there's an S3 gallop on exam. In the real world, patients don't show up with signs saying, I was in British Columbia a couple months ago, or I have an S3 gallop, listen right here. They don't do that. It's a clinician's job and responsibility to, number one, recognize that the travel history is important in that case, and then ask that question. In the case of the S3 gallop, the clinician has to recognize, number one, that listening to the heart is important in this case. Number two, has to have the skills to properly listen to the heart. Number three, has to recognize and identify that S3 gallop. And then number four, has to understand how that S3 gallop influences or shapes the case. So it's multi-layered. Replace clinicians. I think we can imagine a world, and it probably already exists, where you have a machine and you input information or clues into that machine and it will output a diagnosis. But someone has to acquire the clues that go into the machine, and that's what a clinician does. So there will always be a role for clinicians in the diagnostic process and in patient care. I'm going to illustrate how important the first two steps of the diagnostic process are: knowing what information is important to acquire and having the skills to acquire that information, by taking us through three cases. And in each of these cases, the patient's presented with dyspnea. So again, feel free to use the chat to interact with me. I might pose a question or two, but really it's mostly for you just to kind of ponder, for a moment before I reveal the answer. But in this particular case, this is a gentleman who presented with dyspnea, as I mentioned, and three images are presented here. There's an image of the patient's mouth, an image of the patient's hands, and an image just think for a moment if you can identify abnormalities or findings in these images and whether you can put it together to make a diagnosis. In the first image of the patient's mouth, we see a high arched palate, an ogival arch, high arched palate. In the second image, we see long spindly fingers, and that is arachnodactyly. And in the third image, we see a couple of things, including a scar, an older looking scar on the patient's chest wall, but he also has a pectus deformity in the form of pectus carinatum. And I think that we can all put these findings together to come up with a diagnosis of Marfan syndrome. And again, when these images are sort of lined up or presented to someone in this way, or on a standardized test, they might simply tell you the patient has a high arch palate, arachnodactyly, and a chest wall deformity. It's not that difficult, or at least it's a lot easier to come up with the diagnosis, unifying diagnosis of Marfan syndrome. But we want to be the clinicians that can not only synthesize information, that's important, obviously that's step 3, but we want to be the complete clinician, one who can do all 3 steps. So when Marfan syndrome enters your mind as a possibility or a hypothesis, you would understand and recognize that not only is it important to look at the patient's mouth, but it's important to recognize a high arch palate. Not only is it important to look at the patient's hands, but you have the skills to recognize arachnodactyly. Not only do you recognize that it's important to look at the patient's chest wall, but we can identify and recognize a pectus deformity. That's the complete clinician, one who can perform all 3 steps. And we're not done with this case. Remember, this patient presented with dyspnea. So just ask yourself, what valvular condition do patients with Marfan syndrome frequently develop that can lead to dyspnea or shortness of breath? And they frequently develop aortic insufficiency. And so if you have aortic insufficiency in your mind, what should we anticipate hearing when we listen to the patient's heart? And anticipation is so critical in medicine. It allows us to see and appreciate things that we otherwise might have glossed over or missed entirely. The eyes can't see what the mind doesn't know, or in this case, the ears can't hear what the mind doesn't know. So it's so important anytime we go to examine a patient or we order an EKG or a chest x-ray or any other imaging study, I try to anticipate what I might see on those studies. I never want to be surprised in any big way by a result. And that happens sometimes and is unavoidable, but try to minimize that as much as possible. And I do that trying to anticipate what I might see. And again, that allows me to see things and hear things that I otherwise might have missed. So when I'm approaching this patient who I think might have aortic insufficiency causing his dyspnea, I'm specifically going to be listening for a diastolic murmur of aortic insufficiency. And that's exactly what we hear. And this is normal. This is a frame of reference. So S1 and S2, and in the case of our patient, we don't really clearly hear the heart sounds. We just pretty much hear a decrescendo diastolic murmur over Erb's point. I'll play that one more time. Now, aortic insufficiency is characterized by a decrescendo diastolic murmur over Erb's point. Now it's becoming a stronger possibility in our minds. And when we go and we look at the patient's neck, we should anticipate something that might be there that we could otherwise easily miss unless we're thinking about it and anticipating that it might be there with regard to the carotid pulse. So what would we expect to see in a patient with aortic insufficiency with regard to their carotid pulse or their other peripheral pulses? You would expect to see what's known as Corrigan's pulse, or a bounding carotid pulse. And that's exactly what we see here. Look at those arterial pulses. Those are quite impressive and definitely not normal, but this is something that someone might gloss over or miss at the bedside unless they were specifically anticipating seeing it. And of course, this patient did indeed have aortic insufficiency. And so it really illustrates how important all three steps of the diagnostic process are. We want to be more than just synthesizers of information. We need to be at the bedside, hearing that diastolic murmur, observing the Corrigan's pulse, and that all helps us arrive at the correct diagnosis. Let's move to patient number 2. And hopefully these videos are playing in good resolution for you guys. This is a video of a patient's jugular venous pulse. And so as you're watching this video, try to identify what qualitative abnormality is present in this patient's jugular venous pulse. And hopefully you can see it moving there where that cursor is in the middle of the neck, and the patient takes a breath in and it starts to climb up the neck. And now it's all the way at the top of the neck near the angle of the patient's jaw. And this is known as Kussmaul sign, or a paradoxical rise. That's right, Nate. Good to see you, Nate. This is a paradoxical rise in JVP with inspiration, known as Kussmaul sign. It's associated with several cardiac and pericardial abnormalities or conditions. What else is present on this patient, or can we observe on this patient? There's a mark here, a bluish circular mark right below the A wave in the logo. And think to yourself, what could that mark represent? And what if I told you that there were several such marks and they were kind of arranged in a field on the patient's chest wall? These are radiation tattoo markers, indicative of prior radiation to the chest wall. So how can we put these two clues together, Kussmaul sign and radiation therapy to the chest, to explain this patient's dyspnea, or at least come up with some hypotheses? And again, if we think back to that machine that I mentioned earlier in the talk, and we input Kussmaul sign and radiation therapy or mediastinal radiation therapy, that machine will come up with a list of diagnoses. It might say this patient could have constrictive pericarditis from the radiation leading to Kussmaul sign. So it could say the patient could have interstitial lung disease from the radiation leading to cor pulmonale and right heart failure and Kussmaul sign. It could be radiation-induced valvular disease leading to Kussmaul sign. The point is that any machine or robot can synthesize these clues to come up with the correct diagnosis, which in this case, and here's an up-close photo of that radiation tattoo marker, in this case is constrictive pericarditis. Any machine or robot can come up with this diagnosis when given those clues. Clinicians would recommend tattoo markers. That's the clinician that we want to be, one who is observing these clues and findings at the bedside. And I remember when I was a student hearing that, Kussmaul sign is it's so rare that you might see it once or twice in your career. And I see this sign once or twice a week when I'm on service, at least. It's a very common sign, actually. But I think we've been trained to neglect the physical exam a little bit. And again, when you don't anticipate seeing something, or when you don't look for something, it's very challenging to find it. Let's move into patient number 3. And again, this patient is presenting with dyspnea. In addition to that, this patient is presenting with the clinical syndrome of heart failure. So he has weight gain, orthopnea, PND, and elevated JVP. And here are his vital signs. And what do you notice about the vital signs here? Is there any vital sign in particular that stands out to you as potentially abnormal? It's the blood pressure. He has quite a wide pulse pressure, meaning the difference, right, Rabia, the difference between the systolic pressure and the diastolic pressure is quite large in this case. And what condition do we normally associate with wide pulse pressure? It's a knee-jerk response, at least it is for me, when I see, that's right, Rabia, again, aortic insufficiency. So now I'm thinking, could this person have aortic insufficiency? Before I've even met him, I see the vital signs and I'm anticipating what I might see at the bedside. So what I do next is I look at the patient's hands. I'm looking at his fingernails. And why would I look at a patient's fingernails who might have aortic insufficiency? I'm looking for a particular sign this patient does indeed have. And hopefully you can appreciate the finding in this video, but the nail beds are pulsating. I'm hoping that you all can appreciate that in the video. But he has what's known as Quincke's pulse, or pulsating nail beds. And again, it's a sign of aortic insufficiency. So now we have the combination of a wide pulse pressure and Quincke's pulse. So I'm thinking for certain this patient has aortic insufficiency. But what if I told you that he had no diastolic murmur on exam, And when you get the echocardiogram, it shows a completely normal aortic valve without any evidence of aortic insufficiency. And it also shows normal systolic function. In fact, the echo was read as completely normal. If some of you are thinking, well, the echo must be wrong and the physical exam right. Well, I love what you're thinking, but in this case, that even though I've seen that on more than one occasion, that's not the case here. That's exactly right, Adnan. You want to think about, now we have the combination wide pulse pressure and Quincke's pulse. It turns out not specific for aortic insufficiency. Those are just physical findings of high output physiology. And there are other things that can cause high output physiology other than aortic insufficiency. And Adnan is exactly right. We have a gentleman with the clinical syndrome of heart failure, and now with physical findings of high output physiology. He has high output heart failure. And when you do the right heart cath, you discover that his cardiac output is 13 liters per minute, which is, almost 3 times normal. And so you confirm the diagnosis of output heart failure in this case. And what are some of the causes of high output heart failure? It's one of those things in medicine, it's a diagnosis, but it's not really a diagnosis. It's like anemia. Yeah, it's a diagnosis, but now you have to come up with the cause of the anemia. And the same is true in somebody with high output heart failure. So we think about things like thyrotoxicosis, severe anemia, think about, shunts, left to right shunts. You think about thiamine deficiency or wet beriberi. And if you're thinking about these things, they become hypotheses, and that informs us what we need to know from the patient. And so I would then go back, if I haven't already, and ask the patient, do you have one of the risk factors, the biggest risk factor in the Western world for thiamine deficiency, which is, of course, alcohol use. And it turns out he's drinking 3 to 4 glasses of wine a day. And so it does have heavy alcohol use and a setup for thiamine deficiency. And when you check the lab, you check the thiamine level, it's of course very, very low, confirming the diagnosis of thiamine deficiency and wet beriberi in this case. And why is this case so important to highlight here? Well, I would think that in most circumstances, this patient would have come in, the heart failure would have been recognized, and in the setting of a normal echocardiogram, he would have been given the diagnosis of heart failure with preserved systolic function, which is not an uncommon, it's a very common diagnosis. Half of all heart failure patients have this syndrome. He would have been given this diagnosis, and he would have likely been sent home with diuretics and said, we're not sure why you developed this, but hey, it's common. Take these pills, once or twice a day, and you should be fine. And he would have been on diuretics for the rest of his life. And observing those findings, observing the wide pulse pressure, observing the Quincke's pulse, allowed for the diagnosis of output heart failure, which is entirely treatable. And by the way, are we looking at fingernails in every patient that we evaluate? No, we did it in this case because we had a hypothesis based on the wide pulse pressure, and we were thinking aortic insufficiency or signs of high output physiology. And so, of course, we had the diagnosis of wet beriberi here. And again, it's so important because this is totally treatable, curable, in fact, with alcohol cessation and thiamine replacement. We can see what happened to this patient's blood pressure over time. Blue up here, let me switch to laser pointer. The blue line up here is his systolic pressure, orange line pressure. And we can see that here's a start of therapy, and here he's treated over the course of 20 to 30 weeks with alcohol cessation and thiamine replacement. And his pulse pressure completely narrows over time, starting at around 100 down to about 60, totally off diuretics, cured of heart failure because these findings were observed at the bedside. And again, they were anticipated. And again, it's about finding those clues. Again, 10 detectives could evaluate the same crime scene, and some of them are going to miss really important clues at that crime scene. The same is true as clinicians. So we have to be the clinician that observes, notices the wide pulse pressure, observes the Quincke's pulse, makes a diagnosis of high output heart failure in this case. So again, to summarize the process of making a diagnosis, a clinician has to do 3 things. 1, know what information is important to acquire. 2, have the skills to acquire that information. And 3, synthesis is absolutely important. We have to put those clues together to come up with a diagnosis. Now we're going to spend the rest of the talk focused on step number 1, which is knowing what information is important to acquire. How do we know what information is important to acquire? Well, one strategy is to develop a differential diagnosis. I try to identify a symptom or a physical finding or a lab abnormality that I can generate a differential diagnosis around. And the earlier we do this, the better. Why? Because now our interaction with that patient is entirely hypothesis driven. What we have, what the differential diagnosis is a collection of hypotheses. And that collection of hypotheses tells us what information we need to ask of the patient, what physical findings we need to look for, what labs we need to order in order to rule in or rule out a particular diagnosis. And it's always a back and forth. I almost never conclude an admission or a patient interaction in one swoop. For me, it's a back and forth between my differential that I'm constructing, sometimes in my head, sometimes I'm at my desk writing it out or referencing something. And if I see that heart failure is on the differential diagnosis and I fail to do so, I would absolutely go back to the patient and I would ask specific historical questions that are hypothesis driven. Any weight gain? How about orthopnea or PND? When I examine the patient, I'm specifically looking at the JVP. I'm specifically listening for an S3 gallop. That's how I'll be able to hear it. And so it should be a back and forth between your collection of hypotheses and the patient. And by the way, the history and the exam are all you need to make most diagnoses. We don't want to be the clinicians who are ordering the shotgun approach in terms of ordering every lab or imaging study imaginable on all our patients. That comes at a great cost to patients, not only literally because these tests cost money, but also figuratively, because testing begets more testing and sometimes begets invasive procedures which have complications. Imagine a patient who gets a CAT scan unnecessarily that shows a lesion in the liver that's totally benign and otherwise causing no harm to the patient. Now that lesion gets biopsied, the patient has a hemorrhagic complication and is now fighting for his or her life in the ICU, all because of an unnecessary CAT scan. So part of diagnostic reasoning is being a steward and only ordering the tests and studies that we need to order that are hypothesis driven. Thinking back to patient number 3, do we order thymine levels on every patient we ever encounter? We're definitely not doing that. We did so in this particular case because we had a hypothesis, and that study, that lab, confirmed our hypothesis to be true. A little more on differential diagnosis. It's important to recognize that it should be more than just a list. A differential diagnosis should be organized in some way. And the non-medical example I like to give is, imagine if I asked you to name all the states in the United States of America as quickly as you could randomly. You'd get going for a period of time and eventually you'd slow down and come to a stop. If instead of doing it randomly, you thought, okay, I'm going to do this with a method in mind, and let's say alphabetically, I'm going to start with the states to start with letter A, then move to B, then C, then D, and so on and so forth. Or you did it geographically and said, okay, I'm going to start in the Northwest, then I'm going to do the Southwest, then Northeast, Southeast. You'd be a lot better off. And the same is true in medicine. As internists, we're asked to recall the long differential diagnosis for so many problems. There are 30 things that cause chest pain, 30 things that cause dyspnea. There's a whole host of systemic vasculitides. And it's really challenging to wrap our mind around these differentials when they are not organized in any way. So I would say, try to avoid kind of filing this into our brains in this kind of linear, haphazard way. It should be organized. And here's that same list of systemic vasculitides organized into a framework. And that's what a framework is an organized differential diagnosis. So here's systemic vasculitis organized by classic framework: size of blood vessel involved, large vessel, medium vessel, small vessel. It's so much easier to approach this problem or recall this differential when it's organized in this way. And that's one of the benefits of the framework system, is it really enhances memory and recall. And this is evidence-based. They did studies back in the 50s and 60s in the memory and learning literature, where they took a group of individuals and handed them a list of words and said, review these words and memorize them. They gave a second group of individuals the same list of words, but instead of being listed randomly, they were tethered together in some way to form a framework. And here's one of the examples from one of those studies. This is a framework for minerals. And they tested that group later on, and lo and behold, the group that had the benefit of a framework was much more successful at recalling that list of words. The other nice thing about having a framework when you're approaching patients and their problems is that it can often suggest a diagnostic workup. It becomes built into your approach to a problem. For example, systemic vasculitis, you'll notice that the small vessel arm subdivides into ANCA positivity. So if I'm approaching a patient with small vessel vasculitis and I'm armed with this framework, this automatically suggests to me a serologic study that I might be interested in obtaining. The same is true for the approach to pleural effusion. which subdivides into transudate and exudate, which of course is based on Light's criteria. So if I'm evaluating a patient with a pleural effusion and I have this framework in mind, it tells me, hey, you might want to consider getting a thoracentesis and sending that study or that fluid for LDH and protein so that I can calculate Light's criteria and figure out the nature of this fluid. So can really build in a diagnostic workup into your approach to these problems. And we'll give one other example of hyponatremia, the hypotonic arm, of course, subdividing by volume status, hypovolemic, euvolemic, hypervolemic. So if I'm approaching a patient with hyponatremia, I'm going to pay very careful attention to volume status. I'm asking questions that pertain to PO intake, GI losses. On exam, I'm paying careful attention to the jugular venous pulse or pressure. I'm also paying attention to whether there's peripheral edema or not. So it becomes ingrained in my approach to hyponatremia. Those are the two benefits of the framework system. And let's take what we've learned so far, what we've reviewed so far, and apply it to a case. And this is a case from the book. And you'll notice that I've concealed some of the information from this case. And I've done so purposefully because, as we mentioned earlier, standardized tests tend to give you all the clues that you would need to solve a case. We don't want to do that. We want to understand what information we need to gather from the case. And we're going to do that by building a framework for a problem in this case. And that framework will be our collection of hypotheses and will tell us what information we need to gather from the case. We'll gather that information and then we'll come up with a diagnosis. So this is a 51-year-old man with a history of chronic hepatitis C infection complicated by cirrhosis, who presents to the emergency room with shortness of breath. He has been followed by a hepatologist for management of hepatic encephalopathy, ascites, and esophageal varices, which have been stable for several years. The patient has a history of shortness of breath that typically resolves following large volume paracentesis, which he has occasionally required. Over the past few months, the patient has noticed progressive dyspnea despite control of the ascites. Heart rate is 100 beats per minute. Respiratory rate is 24 breaths per minute. Hemoglobin oxygen saturation by pulse oximetry is 85% on room air. Arterial blood gas on room air shows that the pH is 7.48. Partial pressure of carbon dioxide, or PaCO2, is 32 millimeters of mercury. And the partial pressure of oxygen is 56 millimeters of mercury. What is the most likely cause of hypoxemia in this patient? So we should choose a problem from this case to build our framework around. And there's two obvious choices. I think dyspnea and hypoxemia are obvious, and either one would be a good choice. Sometimes when a patient presents with multiple disparate problems, these are quite related, so I think you'd be fine picking one framework and going with it. In patients who have multiple disparate problems, it can be very helpful to build multiple frameworks and kind of focus on where the overlap lies between them. And that's similar to how a Venn diagram works. For the sake of this talk, and so that the rest of my slides are relevant, we're gonna go with hypoxemia. So we're gonna build our framework around hypoxemia. Before we do so, we're gonna just review the basics of hypoxemia just with this one slide. So what is it? Hypoxemia is a physiologic state in which the partial pressure of oxygen in arterial blood is abnormally low, with normal being defined as 80 to 100 millimeters of mercury. And we all remember the oxygen hemoglobin dissociation curve. So on the x-axis, we have the partial pressure of oxygen in arterial blood. And on the y-axis, we have the percent saturation of hemoglobin. And obviously, as the partial pressure of oxygen goes up in blood, so does the saturation of hemoglobin, but it doesn't do so in a linear fashion. There's an S shape to this curve. And the numbers that I like to commit to memory, just to serve as nice frames of reference for me when I'm thinking about this problem, hypoxemia, and what percent hemoglobin might be saturated, I like 27 and 60. Why 27? Because that corresponds to 50% hemoglobin saturation. Why 60? Because that corresponds to 90% hemoglobin saturation. So it just gives me a good sense of how, a nice frame of reference for thinking about hypoxemia and SpO2. Let's build our framework for hypoxemia. So the first branch point here is whether the patient has a normal AA gradient or an elevated AA gradient. So of course that begs the question, what is an AA gradient? And I know this is review for most members in the audience, but humor me, we'll go through this. So what is an AA gradient? An AA gradient is the difference in partial pressure of oxygen between the lungs, the alveolar space, and the arterial blood. So we breathe in oxygen here, it fills our lungs and provides a certain partial pressure of oxygen in this space. And it hopefully diffuses across into our arterial blood. but the AA gradient is the difference in oxygen content here compared to here. How do we calculate a P big AO2 or the alveolar oxygen content? How do we calculate or obtain the P little AO2 or arterial oxygen content? Alveolar oxygen content is calculated using the alveolar gas equation, and P little AO2 is simply measured. It's not a complicated calculation. It's a measurement on a simple arterial blood gas test, or ABG. So let's focus for a moment on calculating P big AO2. And I know that it can be very off-putting or intimidating to see equations in medicine. I don't like looking at them either, but this is one equation that I would really encourage, the students and residents in the audience to really commit to memory. It's similar to, it can be very helpful for understanding hypoxemia, and it's similar to cardiac output equals heart rate times stroke volume. It's so helpful to understanding cardiac physiology. The same is true of the alveolar gas equation. It really breaks down to two terms. P big AO2 is equal to the fraction of inspired oxygen multiplied by atmospheric pressure. And this term here is really just a function of how much oxygen is available to breathe in. And you're subtracting from that PaCO2 divided by the respiratory quotient. And PaCO2 is a function of ventilation. So this term gets at how much oxygen is available, and this term gets at how well you're bringing it into your lungs. So what is the fraction of inspired oxygen to room air? 21%. Barometric pressure at sea level is 760 millimeters of mercury. Water vapor pressure is 47. Normal partial pressure of carbon dioxide in arterial blood is around 40 millimeters of mercury. And the respiratory quotient has to do with diet, and it's sort of the amount of carbon dioxide produced per oxygen consumed. Not terribly important for this discussion, but it's usually around 0.8. So let's calculate the PaO2, P big AO2 here in Portland, Oregon, where we're pretty much at sea level. I gave this talk for a group in Mexico City, and I realized that they were at quite an elevation, 7,000 something feet. So the numbers change for them a little bit. But here in Portland, if we plug in those values that we discussed, we come out with a number of around 100 millimeters of mercury. So that's how much oxygen is in my lungs. And if there is no AA gradient, meaning that the oxygen diffuses across as it should, and my arterial blood has a content of 100 millimeters of mercury as well. That's why I'm satting 99 to 100% if we use the curve. If we calculate this value for individuals in Mexico City, as I mentioned, atmospheric pressure, they're at quite an elevation, so it's no longer 760, it's more like 580. And because of compensatory hyperventilation, their PaCO2 is normally around 30. And so we come up with a value of 75 millimeters of mercury. And again, with a 0 AA gradient, with totally pristine lungs, individual in Mexico City is satting around 93% on room air because of the elevation. Turns out we're allowed a little bit of an AA gradient. So, and it depends on age. At age 20, we're allowed a gradient of up to 17. At age 80, we're allowed a gradient of up to around 38. So let's get back to the framework for hypoxemia. We're going to focus on the arm of the framework in which there's a normal AA gradient. And for the students and residents, when I was learning this stuff, I remember thinking, it seems so paradoxical. How can someone be hypoxemic with a normal AA gradient? So it really comes back to the fact that the little a is at the mercy of the big A. The little a can only get as much oxygen as is available in the lungs. And so it gets back to the alveolar gas equation. What would compromise big AO2, which will of course compromise little AO2? Well, it comes back to these two terms. If the amount of oxygen available is compromised in some way, or the patient is hypoventilating and their PaCO2 goes up, either one of those things will cause P big AO2 to go down. And little AO2 is at the mercy of P big AO2. Even with perfect diffusion, if big AO2 is low, so will little AO2. And these two subcategories include reduced partial pressure of inspired oxygen and hypoventilation, as we talked about. Now let's go through an example just to drive this point home. Let's go through an example of a patient with a PaCO2 of 80, clearly hypoventilating. If we plug in the numbers and instead of 40, we use 80 for PaCO2, his lungs are only seeing a partial pressure of oxygen of 50 millimeters of mercury. And even if he has pristine lungs with 0 AA gradient, well, little AO2 will also be 50, which is clearly hypoxemic. And he'll be satting it at around 85%. So here's a great example of a patient who has a normal AA gradient, but is clearly hypoxemic. And with that in mind, we can sort of fill in the framework here and the differential. So what are the main causes of reduced partial pressure of inspired oxygen? We talked about elevation, it can be polluted air. You know, on Independence Day, we pollute our air with a bunch of fireworks. Hypoventilation, we're all familiar with toxins in terms of narcotics and benzos that are used in our patients, sleep apnea, neuromuscular disorders, et cetera, and so forth. Let's shift gears and talk about the arm of the framework in which there is an elevated AA gradient. So here we have content in our lung, oxygen content in our lung that's different than the arterial space. And it turns out there are roughly 4 mechanisms by which this occurs. On the far left, we have VQ mismatch in the form of dead space. So V represents aeration of the lungs, Q is perfusion to the lung. And we generally like those to be roughly 1-to-1, that ratio. And here we have a situation where V looks good. The lung, the alveoli are being aerated normally, but there's a compromise to blood flow. So V is good, but Q is bad. So we have VQ mismatch in the form of dead space. In the next example here, or mechanism, we have normal blood flow to that lung. So Q is okay, but V is now compromised by something filling that the alveolar space. So we have VQ mismatch in the form of physiologic shunt. In the third category, Q is okay, V is okay, but there's something hampering the diffusion of oxygen across, maybe some fibrosis or thickening there of the capillary membrane. And in the final example, aeration is good, perfusion is good, and the membrane's fine. But here we have an anatomic shunt carrying deoxygenated blood all the way across to the oxygenated side. And so those are the 4 basic mechanisms by which we can develop an AA gradient. So let's just flesh out this differential a little bit here. So what is the classic cause of dead space, where you have decreased perfusion to an area of the lung with normal aeration? And the classic example there would be something like a pulmonary embolism. Exactly, David. And there are some other causes as well: emphysema, hypotension, pulmonary hypertension. You get less blood flow relative to aeration, vasculitis causing a capillaritis, and so on and so forth. In terms of physiologic shunt, what can the alveoli be filled with? What can we think of? Or perhaps it's not filled with something, perhaps it's collapsed. So things like atelectasis, or maybe it is filled with blood, pus, water. So diffuse alveolar hemorrhage, pneumonia, pulmonary edema, both cardiogenic and non-cardiogenic, airway constriction from bronchiolitis or COPD or asthma, hepatopulmonary syndrome. In the setting of impaired diffusion, by that mechanism, what disease typically causes thickening or fibrosis that impairs diffusion of oxygen across? And that classic condition there would be interstitial lung disease or pulmonary fibrosis. And then in the final category, we should think, where are the 2 main organs in which significant right to left shunt develop? Well, that's the heart and the lungs, where we develop significant right to left shunting. And this is the full framework or approach to hypoxemia. Now we're armed with a collection of hypotheses, and this will really help us approach the case that we have. We have the bare bones of a case. We have a gentleman with cirrhosis who's presenting with shortness of breath, hypoxemic on exam. And the first question we would want to know, if we're approaching this using our framework, is what is the AA gradient in this case? So let's calculate that. We have the partial pressure of carbon dioxide, which will allow us, assuming he's roughly at sea level, we'll assume this patient's here in Portland, Oregon. In fact, he was here in Portland, Oregon. I saw him at OHSU. We will go with those numbers, 760, and we know his PaCO2 is 32. When we calculate what his lungs are seeing, he's seeing a partial pressure of oxygen of 110 millimeters of mercury. What's little AO2 in this case? Well, we're told that it's 56, and again, that's a measurement, not a calculation. So 110 minus 56 is an AA gradient of 54, which is elevated in any case. He's in his 50s, so he's allowed up to a gradient of 27, and this is twice that. So we know that his AA gradient is elevated, and we now can focus on a smaller collection of hypotheses. Anytime you can use a framework to divide your differential diagnosis into half, and you can focus on half of the differential, you're on the right path to making a diagnosis. And perhaps we can now go through the exercise that I mentioned earlier. Now we have a collection of hypotheses, and now we're going to anticipate and identify the pieces of the history, the exam, and the labs that we would want to know about this patient given our collection of hypotheses. And so if we just do this one at a time, and we won't go through all the diagnoses here, but maybe one in each arm. So pulmonary embolism, for example, this tells us if PE is on our differential, that tells us we should be asking about risk factors for DVT, stasis, injury to the leg, a personal or family history of clotting disorders, long plane flights. Are we asking all of our patients if they've recently been on a long plane flight? No, but we are in this case because it's a hypothesis-driven question. It tells us what we need to ascertain from the history. On exam, we might specifically looking for signs of DVT, swollen, red hot swollen leg. We're looking for an elevated JVP, maybe a loud pulmonary component of S2. If we move into the other arm of the framework and we're thinking about pneumonia, again, we're asking about cough, we're asking about purulent cough. We're really focusing on a focal lung exam, tubular sounds, rowels or crackles, egophony, might trigger the acquisition of a chest x-ray. Should every patient that we ever see get a chest x-ray? They often do in the hospital. Should they? I would argue that everything should be hypothesis driven. And then our collection of hypotheses here does command a focal lung, a very good lung exam and perhaps a chest x-ray or lung imaging. If we're thinking about interstitial lung disease, we're specifically thinking about the causes of interstitial lung disease. Do they have a connective tissue disease? Do they have exposures to smoke or other environmental or work-related toxins? On exam, it's a particular type of crackle. It's a fine Velcro-like crackle. In terms of anatomic shunt, right to left shunt, what would we be looking for on exam in these patients that we might otherwise miss? We're looking for cyanosis. We're looking for what finding in the hands, often missed by clinicians unless you specifically look for it. We're looking for clubbing in that case. And how could we, and don't forget about testing. So if it's interstitial lung disease we're interested in, we're thinking about high resolution CT scan. We're thinking about pulmonary function tests. If it's a shunt, we're thinking about an echocardiogram, not just any echo, but one with a bubble study or agitated saline, where you inject agitated saline into the right side of the heart, and normally it travels to the lung. That blood travels to the lung. Those bubbles get dissipated in the lung, and none of them return to the left side of the heart. If we see bubbles show up on the left side of the heart, we know we're dealing with a right to left shunt. So we have all of these ideas in our head when we approach this patient. It becomes a much more efficient interaction, cost-saving interaction with the patient. And are there any entities on this list that we should hone in on in particular, given that our patient has cirrhosis? Well, I would argue that there are a couple that we should specifically hone in on. One might be a pleural effusion. Could he have ascites with a hepatic hydrothorax? And again, we're paying very careful attention on exam. We're percussing for dullness. We're feeling for decreased or absent tactile phrenitis. Another diagnosis here that's perhaps a little bit more rare would be hepatopulmonary syndrome. So what is this condition? Patients with cirrhosis develop dilated pulmonary capillaries at the base of their lungs, and that gives rise to disproportionate Q compared to V. So they have BQ mismatch in the form of shunt at the base of their lungs. And sometimes they actually develop AVMs as well. So it truly belongs in both categories. It's a physiologic shunt, but it can also be an anatomic shunt in the form of an intrapulmonary shunt. And how do these patients present? What type of dyspnea do they develop that we should specifically ask about in this case that we otherwise might not ask? Again, we cannot ask every patient a million questions. There's an unlimited number of questions we could ask patients, but we ask the ones that are high yield and hypothesis driven. So we would specifically ask about whether their dyspnea is positional. And in patients with hepatopulmonary syndrome, they develop, because those AVMs and the shunt physiology is at the base of the lungs, when they're sitting upright, the shunt fraction increases because of gravity, more blood flow to the zone 3 of the lung. And so they get an increased shunt fraction. They experience more dyspnea in the upright position that improves when they lie flat, because now when they're lying flat, the distribution of blood flow is more even and there's less BQ mismatch and less shunt. So they feel better in the supine position. So that's called platypnea. The exam finding equivalent of that is orthodeoxia, where they desat in the upright position or their saturation is lower in the upright position that improves upon assuming the supine position. We would specifically be looking for clubbing in a patient or cyanosis in a patient that we think might have hepatopulmonary syndrome. So now we're armed with the information that we want to gather from the case. So let's get back to our case, and we'll slowly reveal the findings that I have concealed from you, or the information that I've concealed from you. So in paragraph 1, we learn that the patient's breathing seems to improve when he lies on his back. Bingo, that is platypnea. And we specifically asked him that question because hepatopulmonary syndrome was in mind. In the second paragraph, we learned that the hypoxemia improves when the patient goes from the upright position to the supine position, from 85% to 96%, orthodeoxia. There are multiple spider angiomas on the anterior chest. He has cirrhosis, so that's not surprising, although I will say that I've seen several cases of patients over the years who have been diagnosed with cirrhosis who didn't have these findings on exam, who ended up having right heart failure and constrictive pericarditis and were misdiagnosed with cirrhosis. So that's an important finding. JVP is 7 centimeters of water, normal. So again, that takes away, we thought about pulmonary edema and cardiogenic pulmonary edema. That makes heart failure a lot less likely in this case. The lungs are clear to auscultation. That makes heart failure unlikely. It makes things like pneumonia unlikely, pleural effusion unlikely. And then we have an image of the patient's hand. And what does this image demonstrate here? You would see 2 findings. It's a black and white photo, so one of them difficult to appreciate, but he has cyanosis as well as clubbing. And again, this is something that, if you had 10 clinicians evaluate this patient, I would guess that maybe at least half of them would gloss right over this finding and would not even notice it because they weren't specifically looking for it. And then we're also given some additional information. We have an echo that we asked for with bubble study, and we can see the bubbles in the right side of the heart over here. There's nothing on the left. 8 cardiac cycles later, now all of a sudden those bubbles show up on the left. And so that tells us there's a right to left shunt, likely intrapulmonary, because it took 8 cardiac cycles. If it happened quickly, that would be evidence of a intracardiac shunt. And so now we have all the information that we need to make, the diagnosis of hepatopulmonary syndrome. And again, it's one of those diagnoses that elude clinicians because that hypothesis isn't generated and doesn't generate specific questions and physical findings to look for on exam. In summary, we talked about diagnostic reasoning, and the way I define it is the acquisition and use of clues from the patient's history exam and other data to make a diagnosis with a hard emphasis on acquisition. And we want to know what information we need to learn from a patient, and we do so by choosing a framework early on. That gives us the ability to perform a hypothesis-driven workup. That's the talk. I thank you guys so much for having me. Here are the references, and here are some other resources on diagnostic reasoning. There's a textbook, of course, which has 50 similar chapters. Each chapter, the framework is is the basis of the book, but each chapter starts off with a case similar to the one that we work through together, and then it kind of uses questions and answers to build a framework over the course of a chapter. And so hopefully you're learning clinical pearls along the way, and then at the end of the chapter, you're left with a full framework for that problem. We're doing things on social media as well as YouTube, and we have a new website called Physical Diagnosis PDX, completely free. It's an academic and scholarly endeavor. Years and years of physical findings are on that website, and the idea, the hope, is that it helps clinicians satisfy step number 2. Again, it's not enough to know that a good heart exam is important in a case. We have to have the skills to hear the S3, to hear the pericardial knock. This site will hopefully, supply so many examples of these findings that clinicians will now recognize, that's what a high arch palate looks like. That's what a arachnodactyly looks like. And there's some additional podcasts that I would recommend as well. Thank you very much for having me. I'm happy to answer any questions that you guys may have.
Thank you very much, Dr. Mansoor. I think one of the terrible things about Zoom is it's hard to give you a round of applause, but that was a beautiful grand rounds and really emphasizing the importance of our clinical skills. and how we need to teach them. And I know the Shaia family would just be delighted that you were here today to give that lecture. So there's a great question in the chat from Dr. Alan Dow, who's the lead of our hospital medicine program, and is asking you, your approach seems to have profound implications for how we teach medical students. How would you like to see medical students change?
Yeah, that's a great question. Thank you for asking that question, Alan. I think that students need a foundation of knowledge, obviously, and that gives rise to the lecture-based curriculum that characterizes generally the first 2 years of medical school, or the preclinical years that you allude to. But I think that it would be very important to also, instead of focusing so much on the details, which is important, and they need to have that information, we should also sort of supplement it with kind of these frameworks for thinking about problem-based medicine. These frameworks kind of give the 30,000-foot view. And, this is a different sort of approach than Harrison's, for example, or, Up to Date, or the lectures that they're hearing in the preclinical years, where we're really talking about details and pathophysiology. This is a little bit different, where it gives them the 30,000-foot view, and it kind of shares or tells them how these specific diagnoses that they're learning about, how they fit into kind of a framework for a general problem. And that general problem is what the patient is going to be coming to them with. The patient doesn't come to them saying, I have hepatopulmonary syndrome. The patient comes to them with dyspnea, and they may be learning about AVMs in the lungs, and they may be learning about VQ mismatch in the lung. And this gives them a way of visualizing how that fits into patient care. When a patient comes to them with dyspnea or hypoxemia, they see where hepatopulmonary syndrome fits in that framework. And I think that's the value, is that it kind of gives them both sort of sides of the coin, the 30,000-foot view. And they also, I think it's very important for them to be learning the pathophysiology and the kind of the microscopic view as well. But as far as specific suggestions on how to incorporate it, that I think would be a difficult question to answer, but I would like to see this style incorporated in the preclinical years.
Wonderful. Any other last minute questions in our final minute or two here that we have Dr. Mansoor as a captive audience? Well, I think you've given us lots to think about, and we definitely enjoy the dialogue and really enjoy learning about what you were doing in your institution offline as well, and how things compare and contrast to what we do here. So definitely wish you the very best of luck going forward with all your educational efforts. And I'm sure many of us will be meeting you in the years ahead, and look forward to those interactions. And congratulations on all you've achieved and your book.
Thank you so much, Dr. Simon. It's a pleasure to be here. And I hope that we can do this someday in person. I recognize both Nate and Patrick from the Twitter world, and hopefully I can meet those guys in person and the rest of you someday. Thanks again for having me. I really appreciate it.
Sounds like a really solid plan. We'll do that. Thank you. All right. Thank you, everybody. Have a good afternoon.